Hello and welcome to this video presentation on disorders of the breast. My name is Dr. Kimberly Cheatham. The objectives for this presentation are listed here. The anatomy of the female breast includes glandular tissue and fat that vary with a woman's age and weight. The breast's structural components of lobes, lobules, and acini serve to produce and secrete milk, the primary function of the mammary glands. Ducts and lactiferous sinuses are tubular connections between the lobes and nipples that allow milk to exit the breast. The basic functional unit of the breast is the terminal ductal lobular unit. Most of the benign and malignant pathology of the breast arises in the duct and lobular network. Lymphatic channels travel through the axilla, along the sternum, and above and below the clavicle, so physical examination should include these areas around the breast. Most of the lymphatic drainage of the breast flows into the axilla. Physical examination of the breast should begin with inspection in the sitting position. Look for evidence of asymmetry, although a small amount of asymmetry between the breasts is common and normal. Also look for dimpling of the skin, nipple retraction or inversion, skin color changes, and other abnormalities. Here is an extreme example of breast asymmetry, likely caused by a developmental abnormality. Asymmetry can also occur from pathologic processes such as infection or malignancy. Skin dimpling can occur when a pathologic process such as cancer pulls the overlying skin inward. These pictures contrast a normal nipple on the left with a retracted nipple on the right. Some women normally have retracted nipples on both breasts. If this finding is lifelong, it's likely normal. If retraction is new and localized to only one breast, it's pathologic. This photo demonstrates a large mass located in the lower half of the breast that alters the breast contour while the patient is supine. Pot orange describes skin changes that are similar to the dimpled surface of an orange. These skin changes occur from the edema that results with blockage of lymphatic drainage in the breast due to infection or malignancy. Here is an obvious example of abnormal color change with crusting around the nipple. The technique of breast inspection begins with having the patient remove her gown to allow for full visualization of the breasts in the sitting position. The patient should raise her arms, followed by placing her hands on her hips and tightening the chest muscles. Inspection is followed by palpation of the supra- and infraclavicular lymph node regions, as well as the axillary regions on both sides. The patient should then be placed in the supine position with one breast covered. The exposed breast should be inspected, followed by palpation. Use the pads of the middle three fingers to palpate in a systematic fashion. Different search patterns can be used across the breast, including a wedge approach, concentric circles, or vertical lines. The important point is to palpate the entire breast tissue. Remember to use varying pressures during palpation, from light to medium, then deep, to evaluate the full thickness of the breast. When the first breast has been examined, cover it to maintain patient privacy and expose the other breast for examination. Use of either one or both hands during breast examination is appropriate. Breast tissue, called the tail of Spence, extends into the axilla and should be palpated. Because the nipple may be sensitive, checking the nipple for easily expressed discharge should be performed after warning the patient. This photograph illustrates where different groups of lymph nodes can be found in the axilla and can guide palpation of this area. The best time to perform a clinical breast examination is the week after the patient's menses. During this time, breast tenderness and benign cystic changes are less likely to be present due to lower ovarian hormone levels. Patient complaints of breast symptoms are common and usually represent a benign process. However, patients may have significant anxiety about whether cancer is present. The most common benign breast process is fibrocystic changes. This tenderness and increased lumpiness on examination occurs from an exaggeration of the breast's response to ovarian hormone production. Thus, fibrocystic changes are generally limited to women in their reproductive years. Signs and symptoms of fibrocystic changes are described here. Although a patient will have an increased lumpy feel to her breasts, no dominant breast mass should be present. If a dominant breast mass is palpated, it should undergo proper evaluation, including imaging. If a dominant mass is not palpated, imaging is not indicated. Lifestyle changes, such as the use of a support bra and a decrease in caffeine intake, can be helpful for symptoms of fibrocystic breast changes. Oral contraceptives decrease the occurrence of benign breast cysts and are another option for these patients. Another benign breast finding is a fibroadenoma. Patients present with a breast mass that may have been present for years. On examination, the mass is easily palpated with discrete borders and is typically mobile and non-tender. Ultrasound of the mass demonstrates a well-demarcated solid lesion. These patients should be seen by a surgeon, although surgery is not usually indicated unless rapid growth of the fibroadenoma is occurring. The next benign breast disease finding is an intraductal papilloma. An intraductal papilloma is a hyperplastic growth of tissue found in a duct of the breast. It is the most common cause of bloody nipple discharge, which is the complaint that patients typically present with. Because intraductal papillomas can be associated with premalignant cellular changes, they should always be excised by a surgeon. The next three important processes we will discuss include breast pain, nipple discharge, and a breast mass. Breast pain, also referred to as mastalgia or mastodynia, is categorized as cyclical if it occurs in relation to the menstrual cycle, or non-cyclical if it occurs unrelated to the timing of the menstrual cycle. Breast pain should be taken seriously by the healthcare provider because it can significantly affect a patient's quality of life, even though most causes are benign. Symptoms and pathophysiology of cyclical breast pain are described here. Symptoms and pathophysiology of non-cyclical breast pain are listed here. Note the potential extramammary causes of breast pain that may require additional workup. Evaluation of breast pain includes a thorough history and a complete breast exam. Patient use of a breast pain diary is sometimes helpful to further characterize the breast pain. Because most etiologies for breast pain are not malignant, if the history and physical examination are unremarkable for lesions, reassurance and support for the patient are appropriate. Most breast pain spontaneously resolves over the course of several months. You can recommend that these patients wear well-fitted support bras throughout the day and nighttime, decrease caffeine consumption, and use acetaminophen or ibuprofen as needed. If breast pain is severe and unresponsive to these conservative measures, refer the patient to a specialist. Because non-cyclical breast pain is not related to hormone changes and has a variety of causes, its treatment is more difficult. After extramammary causes of pain have been ruled out, lifestyle changes are still recommended. Severe breast pain refractory to conservative therapy can be treated with several prescription medications. However, the side effects from these medications are often worse than the breast pain. Nipple discharge is another important process a clinician may encounter. It is classified into physiologic and non-physiologic causes. Physiologic nipple discharge is typically a bilateral finding arising from multiple nipple pores on each breast. The discharge is clear or milky and does not contain blood. Oftentimes, physiologic nipple discharge only occurs with expression of the breasts and not spontaneously. In contrast, non-physiologic nipple discharge often leaks spontaneously from one breast, usually from a single nipple pore. This discharge can be different colors and may have blood present. Physiologic nipple discharge is usually caused by an endocrine disorder such as thyroid disease or hyperprolactinemia, or from medications. It also may be a benign finding with no identifiable cause. Non-physiologic nipple discharge represents an underlying pathologic process of the breast. The most common cause is an intraductal papilloma. A palpable mass under the nipple may or may not be present. Important components of the patient history of nipple discharge are listed here. Be sure to ask the patient how often she's checking her breasts for discharge or if other manners of overstimulation of the breasts are occurring. Discharge that only comes out with physical expression is usually benign. However, continual stimulation of the breasts can lead to increased nipple discharge production. Physical examination of the breast should be comprehensive and should evaluate whether nipple discharge is unilateral or bilateral, spontaneous, or requires expression. The color and consistency of the discharge should be noted, and a sample should be checked on a guaiac card for the presence of blood. Management of physiologic discharge includes an endocrine evaluation. Breast imaging is typically not necessary unless a mass is palpated. If the endocrine evaluation is negative and the breast discharge only occurs with expression of the breasts, recommend to the patient to stop expressing her breasts and follow her expectantly. Non-physiologic nipple discharge should be evaluated more aggressively as detailed below. The patient complaint of a breast mass is common and usually benign. However, it should be taken seriously no matter what the patient's age is because of the risk of cancer. Clinicians should pursue to resolution any breast complaints or abnormalities, especially a breast mass. Failure to diagnose breast cancer is a leading cause for malpractice lawsuits in the United States. If you have any doubt about a patient examination, get a second opinion. When a patient presents with a complaint of a breast mass, the history should include the following components. Important risk factors for breast cancer are listed here. One risk factor for breast cancer is a patient history of a previous breast biopsy. The result of the biopsy can indicate whether the patient's risk for cancer is increased. When physical examination is performed, normal breast tissue is often lumpy. Your goal is to determine if there is a discrete dominant mass or abnormal thickening present. Classic physical characteristics of a cancerous breast lesion are listed here. If a breast mass is palpable, its management will depend on the patient history, physical exam characteristics, and the patient's age. Women younger than age 30 with an unsuspicious mass can be watched until the next menstrual cycle. Re-examine the patient after the next cycle. If the mass is still present, a full workup including targeted ultrasound and referral to a surgeon is indicated. Because the risk of breast cancer increases with increasing age, if the woman with a breast mass is older than 30 years, workup should begin immediately. Bilateral diagnostic, not screening mammography, should be ordered along with a targeted ultrasound of the lesion. The patient should then be referred to a surgeon for further evaluation. Mammography is an effective tool to evaluate a breast mass in many women. However, it's not as accurate in younger women with more dense breast tissue. Because of this decreased accuracy, mammography is usually reserved for women over the age of 30 years during the evaluation of a breast mass. If a breast mass is palpable but the mammogram is negative for any abnormality, it is important to still refer the patient for further evaluation. Mammography has a 10 to 20% false negative rate and can miss a cancer that's palpable on exam. Breast ultrasound should be part of the evaluation of all women with a breast mass. It can determine whether the breast mass is solid or cystic. Simple unilocular cysts on ultrasound are considered benign. If a mass is seen on mammography but is not palpable, the patient should also be referred to a surgeon for further evaluation. A major benefit of mammography is that it can detect breast cancers 1 to 2 years earlier than detection by physical examination. In summary, breast masses are common and usually benign, but may represent a malignant process even in young patients. The older a patient is, the higher her risk that a breast mass is malignant. Women 30 years and older should be evaluated aggressively for a palpable breast mass. Women who are younger than 30 years with a palpable breast mass can initially be followed expectantly with re-evaluation after the next menstrual cycle. If the mass is still present, proceed to a proper evaluation. This concludes this presentation on disorders of the breast.